Hello, everyone. I'm Tracy Lewis with We Are Winter Garden, and I'm joined with Pastor Scott, who is the CEO and founder of Matthew's Hope. Also, Sarah Blizzard, who is a medical nurse practitioner as well as a psychiatric nurse practitioner at Matthew's Hope. So welcome to episode 38 of Straight Talk, No BS with Matthew's Hope, where today we're going to be talking about healthcare, mental health, mental illness, and how that all relates to the growing homelessness. So tell
no
us
effect whatsoever.
No, I'm excited for this one. Sarah, tell us a little bit about yourself.
Like you said, I am a family and psychiatric nurse practitioner. So I'm dual certified, which is an advantage for a place like Matthew's Hope because I'm not limited in what I'm able to do. It gives me more of a broad coverage for you, I guess.
Yeah.
Anyway, so I have been practicing in healthcare since I was 21 years old. I've been in the emergency department most of my career. I became a nurse practitioner about 13, 14 years ago. And I love it, and I continue to do it. I started specializing in psych about 5 maybe years ago.
Okay.
And I opened my own practice here in Winter Garden.
That's
so
great.
I have a psychiatric practice, and what we do is we collaborate. Excel Psychiatry.
Yes, I was going to ask, what is that?
So if you need a good head doctor, here you go. I'm telling you, she's good stuff. Okay.
So anyway, what we do for Matthew's Hope is we kind of collaborate together, and my role now. I used to go in on the outreach days, but we found it was too chaotic because we couldn't really. When people are transient, it's very hard to prescribe medication or do things when they're real transient. So we decided that we would focus more on their residential program and their work program, employees, or patients who would be, they come in consistently on a certain day or
Makes
something
sense.
so that we can help them. And that seemed to have gone really well.
And how long have you been with Matthew's Hope?
Gosh, you've been working with us for at least the last couple of years.
Yeah, a little while, yeah.
I mean, we've been, it's one of those things that when Sarah and I first started talking, clearly she has a strong understanding of the role mental health plays in homelessness. And I don't believe the general public really understands how big a role mental health plays, even more so since the pandemic.
So Sarah, we'll get into the mental health in a little bit. So let's talk about health first. What are the common issues that you're finding with the guests at Matthew's Hope?
Currently what I am doing for them does focus more on psychiatric issues. However, when I was there during outreach and what I know is going on, just simply because we just know, we communicate quite a lot. Real common things that people take for granted. They're not able to do things like wash out a wound, like a scratch, or, and then that becomes very complicated for someone. Something that could have just been like, oh, we're going to put a little wash off, put a Band-Aid on it, and you're good to go. It can turn into something life-threatening for them because they're out in an environment where there's no sinks available. Right. There's no, there are, but it's difficult to find. So we see a lot of common things that we see. So a lot of common things that you would see are like patients who have like blood pressure problems. They have, dermatology types, their skin problems. They have infections. They have a lot of dental issues. Basically anything you could think of that would, most of the time, you would see a primary care doctor or somebody for that. You would go and say, hey, I think I have high blood pressure, and you would be treated. They don't have that option. So what ends up happening is they end up in the emergency room for what we would consider minor medical issues that could be dealt with at Matthew's Hope or at other organizations around.
And in some cases, even if they just had a home to be in,
exactly,
where they could possibly wash the one. One of the things I saw early on was most people have scratched a mosquito bite open. Okay. And we go home, we wash it up and maybe put a little antiseptic on it, and it's done. Usually by the next day, it's fine, okay? So I watched the same thing happen with a homeless person, and they scratched it. They got infected. Literally, Sarah, the pus pocket was about this big under their arm. on that arm there because it became so infected to the point where they were getting sick because the
Right.
poison was now spreading through their system.
In their bloodstream.
And
I
it
would have
all
never
started
even thought of that.
mosquito bite.
Just something so minor and something so common for somebody. But if you're homeless, that one little thing left untreated turns into a huge issue. Let's talk about feet because we've talked about feet before. And we're in Florida, so it rains in the summertime every afternoon. How does that affect somebody who's homeless?
Well, I mean, your feet need air, need space. You know, they do. Anything does. You submerge any part of your body into water for a prolonged period of time, you're going to have problems. I mean, think about when you go to the pool and you stay too long, right? You start getting that little shrivelly
little
fingers
purdy,
and stuff. Yeah. It's the same concept, only it's to the extreme. And it doesn't really matter where they are. Being in Florida, being in Michigan, being in California.
So it's happening everywhere.
Yeah, it's universal. When you can't do the things that like we everyday commonly do and we take for granted. I come home from work, I take off my shoes, I go chill, I go take a shower, or I do. That's not available for them. And also they have to deal with things that are like losing things, because if they lose their shoes, they're in trouble. If somebody decides they want to take their shoes because they don't have any, they're in trouble. So the easiest way to protect themselves is to do things like that. Wear something all the time, even though it's detrimental to them.
You know, one thing, you know, since we're talking about feet and shoes, and you know, Lynn's husband comes in as a podiatrist, which is nice on occasion.
Yeah.
She's one of our nurse practitioners also. But, you know, I've had people get upset with me because I request that we only take running or mesh style shoes.
Right.
And the reason I say that is breathable or washable. You know, this is a true story. Actually happened to me early on in the ministry when I helped a man that couldn't get his boot off. I got it off, and you haven't lived until you've taken someone's shoe off and their toes don't come with it.
I've seen it.
Oh,
But the
my
toys are
gosh,
in the.
are you kidding me?
The toes are in the boot like marbles. The good news is that gangrene smells kind of like almonds, so it's not that offensive. Okay.
I'm actually surprised by that, though. I'm surprised he wasn't in the hospital. And
Wow.
yeah.
And the fact that it didn't spread through his whole system yet. But I mean, but you know, what happens is I even worked in footwear for a number of years ago for a company called Brooks. It's a running shoe. And one of the things they said is you shouldn't wear the same shoe twice in this, you know, 2 days in a row.
Oh.
Because you should dry that shoe out before you put another and have shoes that change out. Well, most people, they have their favorite shoes or favorite
Right.
sandals, and that's what they wear over and over again. And the reason they're saying that is because they want that moisture to get out of there, get dry again before you put your foot in there. Now, if you're a homeless person that's wearing that shoe days on end, and then God forbid if you have something like diabetes and you have an ulcer on your foot, and again,
Complicates it
in
even
that
further.
damp, moist, hot environment,
Yeah, he brings up a good point, because a lot of these people that we see have high comorbid conditions, is what we call it.
Okay.
So
What
what
does that
that means
mean?
is they have medical issues that are just adding to their problems. You know, they have diabetes, but because they have diabetes, now they have renal failure. Because they have renal failure and diabetes, their circulation is poor, so they start losing their toes and their feet, and
Oh my gosh.
you know, they start having amputations and things like that. So it's these comorbid conditions that generally, you know, we're very blessed in America. You know, even our homeless have access to medical care. But we also live in kind of an affluent area, and sometimes people take for granted that, you know, oh, I have a headache, I can just go take some Tylenol. I have,
Or
you
go
know,
lay
like
on
I
your
said,
pillow and
right. My
close your
shoes don't
eyes.
fit correctly. I need to probably go pick up another pair. You know, those are luxuries that they're not afforded.
Right.
You know, and everybody on the street does not have mental health issues. I mean, per se. You know, like Scott always said, they may end up with it once they're on the
Right.
street.
yeah.
What are the cares and treatments that you at Matthews Hope are able to provide for the guests?
Well, when they come in those kind of severe things, there's nothing we can do for them except the emergency room in the hospital. I mean, really, that's the only appropriate thing. But patients who could be appropriately treated at Matthews Hope, I think there are a lot of things that we could implement. Now that you have sovereign immunity too, there's
Yeah.
a lot of things that we could offer. Just to keep in mind, I think a simple suture kit would save a lot of ER trips.
Okay.
You know, where we could clean out a wound for somebody, stitch it up. You know, I think having something like where if somebody gets an abscess, it starts where we could do, it's a simple procedure in office that we could do that would benefit these people greatly and keep them out of the ER. But you also have to remember they're short on volunteers and supplies, and what their main goal is basically just to keep them alive for the moment, to get them somewhere where they can be safe, get the health care they need. So some of those things aren't always going to be a priority for Matthew's Hope because they can't be.
Sure.
But as we grow, I think those are definitely things that could be implemented.
And those are definitely things where, I mean, it started by just simply having an RN around 8 years ago.
As simple as you guys must do, like monitor their blood pressure, whatnot.
Oh yeah, I mean the nurses are fantastic. I mean they're doing pill counts to make sure people are being compliant on their medications, which is real
Simple
important.
as a Band-Aid.
It's something as simple as a
keep out
Band-Aid.
infection.
We do a lot of wound care. I will tell you that a lot of people don't realize too that a lot of the homeless, if they get care at a local hospital, and that's a big if.
Yeah.
If they get care, a lot of times it's not the type of care we would get, and there's not a follow-up care. So some of the nurse practitioners and nurses have nursed wounds that were pretty significant.
Absolutely.
That were let out of the hospital that we would have never been let out of the hospital for, or if we were, we would have had follow-up because they've said we got to wash that, repack that injury.
Again, I mean, it's just common things that you don't think about, especially if you are fortunate enough to have health insurance right now. Health insurance is a big issue. There's a lot of things, obviously, that we have problems with healthcare and stuff like that. But in regards to I know that we were going to talk about that a little bit later. But
we can totally talk about it now. Let's move into the mental health.
The problem with the hospitalizations going to the emergency department is very fragmented for them. So, I've worked in the ER for years and years and years. I get it. So a patient comes in, it's the old saying, treat them and street them. That's
and if they have a prescription, how do they fill that if they're homeless?
That's not the emergency room's problem. So that's where, and I hate to sound like cold, but that's essentially it. Their goal is to get them stable and get them moving. So
that's kind of where we fall in a lot of times. If we can get that when they're being discharged, we understand their discharge papers and the follow-up care. That's where we've been able to help them get medications off and get the follow-up visits they need. But otherwise, they get a prescription and a follow-up that never's going to happen.
They're just going to end up back.
But it's also more complicated than that because they when I say fragmented, I don't even just mean follow-up care. I mean per visit. I've had patients go in and they've been taking, let's say they were taking Paxil or they were taking Prozac or something, and they go into the hospital, but the hospital's last record was they were taking sertraline, so they just give them sertraline. And then they come back with this med list, it's all cockeyed and screwed up. And you're like, no, these were corrected, but they've set their whole, I have sent a patient in for something that they really needed to be, but they were on A, B, and C medications. When they came back from the hospital, their medications were completely changed, but they were changed to what they had 3 years ago.
Oh, no.
Because that's what's on their record. So they're not being updated frequently. And I think that's a problem. It's reconciling medications is a problem, just straight across the board. But it's specifically a real huge problem for mental health patients.
So let's talk about mental health a little bit. Scott, I know you've mentioned before there's a difference between mental health and mental illness. Can you kind of dive into that to help me understand?
Well, I can't speak for what he means by that.
So we'll go ahead.
Let me tell you what I mean by that, and I'll let her take it from there.
Yeah.
Here's what I mean. Okay, look, the bottom line, the truth is that I myself suffer from depression. I tried to take my life at one point years ago. I can get by with, I've been on and off medications for years, and I can get by with a pretty low dose of whatever I'm on at this point, okay? But I am considered mentally ill. I fall into that category of being mentally ill. And what I say from that point is that there are a lot of people we deal with in the community. I say if you didn't have a mental health care issue before you were homeless, you will once you become homeless.
Yeah.
And so what I'm saying is a lot of times 20 milligrams of Zoloft may change this person's life before they get to that point that they're walking down the street babbling to themselves and seeing things and having conversations with people that aren't there. they never got any care at the beginning. It only progressively got worse. That's what I kind of mean by that.
Yeah.
And I would say I would kind of say there's two types of. Well, first let me say mental health is basically just a statement regarding. Okay, so this is health in general, health and wellness specific to psychiatric condition. And a lot of times those were looked at as like taboo or whatever. But now we know there's medical issues that are going on.
Okay.
But I also think as far as when people refer to mental illness, I'm not a big fan of that, just simply because it implies they're like crazy or sickly or, abnormal. Yeah.
Okay.
But I will say that as far as having mental illness, that to me is just a problem that has not been diagnosed and treated correctly.
Okay.
So, yes, they're ill, just like they would be if they had diabetes or something. But the stigma is still kind of there, and you'll see that in things like in the news if there's a shooting or something. Oh, they're mentally ill. Well, they may be totally straight. They might just, But what I consider like mentally ill are people who, like I said, not been diagnosed correctly. They've had bad experiences, and there are two types of what I would say mental illness type patients. There's patients that were they are homeless because they have a long history that you could have done nothing about. They were born as schizophrenic.
Okay.
And they were treated, and they don't want to be treated anymore because, schizophrenia can be a very difficult diagnosis, and the treatments can be very difficult. It's almost like what's worse, the disease or the treatment.
Okay.
So they want their freedom. They don't want to be locked up, all sedated. They want to be able to walk around. So that is one type of homelessness that they have chosen
Okay.
because they don't want to be locked up. Now there's the other type of mental illness where somebody, like you said, maybe is having a bad run, which is happening right now. We're seeing a skyrocketing of homelessness due to housing prices and inflation. So they're going to be, of course, I would be severely depressed if I lost my home. And, that's going to come along with it.
Okay.
But they may have never been depressed in their whole life. So we have two types of people. We have people who develop a problem during life. Then they have people who are born with those problems. Is there something that we can do about it? Most of the time, those people we can't help. So that's why they're not in their residential program, because this is a lifelong thing for them. I think Matthew's Hope focuses almost, I like to call it sort of like combat triage.
Okay.
Yeah.
You're going to take the person who has the best chance of survival and success and work on them, because you know that the resources needed for the others are overwhelming.
It's kind of funny you said that, because we used to actually refer to us as a triage mash unit.
Yeah.
Because there's so many, like right now, we're averaging over 800 visits, touches per week between our two campuses.
That's amazing. Yeah.
Okay. And there's a lot going on there, and you've got to sit there and step back and go, okay, what can we do here? One of the things I used to talk about, Sarah, and I use this for my private session while we're sitting here, is I look at things, I see what I call situational depression. Something bad happened at work. Your spouse said something to you that wasn't kind. Your children didn't do something that upset you. Your mother didn't call you. Your children didn't call you your mother. Whatever the case is, it's something that kind of rocks the world there in some way. And so you look at that, and that's situational depression. Then the depression that I deal with is something in my system. It's just part of who I am. When those two collide, that's when it gets real interesting. Is that when I happen to be having a rough time that I can't explain to somebody, but then something happens to rock my world, and those two hit, is where I find that often some of our guests, that's what's happened with them.
Catastrophic.
Yeah, when those two hit, all of a sudden it created the perfect storm for them.
Serendipity.
And the wheels completely fell off. And that's where, as we as an organization do our best to kind of triage the situation and get them to where they're safe for the moment, and then what do we do from here?
Correct.
Are you finding it that those that do have mental illness or mental health, are they resistant on getting help at Matthews Hope, or are they open to it?
You know, from what I see with the nurses over there, they love the staff over there. They love them. So they are not resistant to treatment. Now, they will be resistant to certain types of treatment.
Okay.
Like I mentioned, the schizophrenic. We do have one that it was a female lady, older lady. She'd been schizophrenic like her whole life, you know, pretty much. She would have moments of like agitation and do stuff like that. But she would talk to Linda, and she got to know me. She liked Yandu, you know, my hearing dog. So she would talk to us and she would share. But she was absolutely adamant. You can treat me for anything but my mental health.
Okay. Wow.
Because again, you know, the treatment sometimes can be very difficult.
And when you get to talk to some of these people, you get to know them. It really is that treatment aspect of it can come across as pretty brutal. Like I said, what's worse, the treatment or the actual illness itself? And I can't imagine being there. I used to say that I wanted to be able. There's times where I've known some of these folks for so long, and they might be having some kind of episode of support.
Yeah.
And I say to them something like, "Sarah, you doing okay?" In that moment, they will look at me and say, "Oh yeah, I'm fine." I used to have this guy go, "Hey, yeah, I'm just fine, Pastor Scott. I'm good. Okay."
Yeah.
And then go right back to whoever he was yelling at, whatever. And I often said, I wish I could just enter that world for a minute. And what do they see?
Yeah.
Because whatever it was, it's real happening to them. I entered into that. They were able to acknowledge me and talk to me and then go right back to where they were. Okay. There's been other times where we have had people that are having, I call them blowout. And we've literally been able to, our staff people have been able to kind of talk them off the ledge and talk them down.
That's one thing you guys are great at, is de-escalation. Absolutely. You
Yeah,
guys
even to the point where some of the police departments are really using us more for that.
Right.
Saying, okay, if Matthews Hope can talk to him, because they know, like Charlene said the other day, we're in a meeting with the chief of police over at Cocoa, and she goes, me showing up with a peanut butter and jelly sandwich, you showing up with a badge and a holster. Okay, who's going to be better well received? And so what happens is there's times where they say, is this something Matthews Hope can go out and look at? Is this someone you know? And the nice thing is often is they're not getting arrested when that happens, number one.
Yeah. You've invested. Now, I wouldn't suggest that for other people. They have invested a lot of time in safety, and they have training, and when I say it, they know these people intimately.
Right.
You know, and there's a trust there. So if you were just trying to de-escalate somebody with schizophrenia, you just go out there, you've never seen him before. That's dangerous. We don't recommend that. But what Scott and his staff do, and they're very good at, is, like I said, they build that trust so that even if somebody is escalated to the point of, even self-harm. Yeah. I had somebody one day when I was there, he kept trying to set his hair on fire. Oh, no. But one of the staff, now he was new to me. I was new face. I remember coming in that day. And, he needed to be involuntarily admitted to a psychiatric facility. He did, because he was actively, and he was a danger to other people.
Right.
So, but one of the staff there was able to talk him down enough where he actually gave up his lighter. Wow. And that's huge. Yeah. It was huge. But the guy was big and strong, and so we did have to involve the police. But by the time the police got there, he knew they were coming, and he was more accepting.
And we're able to prepare the police in what they're walking in on.
So I'm thinking about my husband because he's a police officer. Your daughter's a police officer. And laws like the new anti-camping law here in Florida, they often lead to encounters between police officers and those experiencing homelessness. So should we expect police officers to have the same knowledge and skills to be able to handle and encounter a subject or somebody who has mental illness?
I think first off, we are putting our police departments in an awful position.
I agree.
Because they're in a position where they're going to have to deal with something like that walking past us right now, which is someone clearly, I don't have to be an expert to know that that's a mental health issue. But they have not been equipped, and no fault of their own, but I think they're going to have to be more equipped in the future. But we've put them in a terrible situation of enforcing a law when there's no place to go. What a lot of people don't understand also is that if someone is Baker acted or Marcham acted, okay, and they are taken down to a facility, they're going to be at that facility 24 to 72 hours for an evaluation That's as far as it goes. There is not follow-up care. There are not medication distributed at that time. And what ends up happening is a few weeks later, when that person, for whatever reason, has that episode again, they
Right.
go right back through the same process.
Well, and it makes me nervous because, like you said before, you know, that trust. It's a new face, and they're a police officer. So right then and there, they're gonna put up a wall, and they're gonna be
Right.
don't have that trust.
Yeah. Well, yeah, no, I mean, their job is like to protect and serve the community, which is great. But ultimately their job is to enforce the law. So they're in, like you said, a really bad situation because even their training has been on de-escalation and stuff like that, but their training is specific to enforcing the law.
Yeah.
So that's their job. That's their job title.
Yeah.
Right.
Yeah.
So to like expect them to be a therapist, a psychiatrist, a nurse practitioner, a nurse,
Such
or
a good point.
counselor is like stupid.
It's
not
so
in
unfair.
their. It is. It's
kind of
not even in their
dangerous, I
job
feel.
description, really.
Yeah.
Yeah, well, yeah, I mean, to a certain extent, and I think that again, it's kind of like when I went to seminary. You know, I think I had 18 hours of counseling
Right.
classes, right? Hardly prepared me
To be a counselor.
to be a counselor.
Exactly.
Okay,
Yeah.
but I do feel that it's important, will become more important in the future, that police agencies, law enforcement agencies, become more aware, made more aware of some of what's happening out there with mental health. Because when they go de-escalate, there's a different type of de-escalation
Right.
when you're dealing with someone who's completely on the edge, who is looking to often harm themselves more than anybody else. But as they're doing that, they can often come across as being harmful to others.
Exactly.
I don't know how to explain
They
it
may
other
be
than that.
actually.
Yeah, and they may be. The challenge is when you go in there with the automatic thinking that they're going to harm others.
Yeah. Well, you know, and I can't say like I'm a big supporter of the police. Like I can't
Yep, me too.
say to them that I blame them for, you know, having their guard up and ready to draw, you know,
Right.
if they need to.
Yeah.
You know, they
It's a
have to
slippery
protect
slope.
themselves.
It
Yeah,
is.
yeah, really. And I think most of our police officers, like around here that I've encountered, they know a lot of our homeless population.
They
They
do.
are very kind of familiar with
They
a
come
lot
in
of them.
contact with them
Because they've
a
told
lot.
me, oh yeah, we know him, you know. But that still isn't the same amount of trust that, like, it's a whole different organization. It's a whole different purpose. It's ministry based, God based. You know, Jesus did this to help people, so we're following. That's totally different than the police officer who went to school to police and protect. And I think, yes, absolutely, they need those tools given to them, and they should be taught about, you know, some mental health. But I think what might be a better solution is to collaborate more with somebody who's more appropriate for those situations, like a social worker or something like that.
Know what's available.
Yeah.
Right.
And to give them the tools, because here's the other part again, is the general public often has the belief that someone, a police officer, is going to pick this person up and I'm going to take them out and we're not going to have to deal with that again.
Right. No, that's not the case.
Right.
If there is no institutions as we knew them.
Right. Well, that's
And-
the fragmented care.
Yeah,
we were
yes.
talking.
And we, like many things we do in this country, is we swing way to the right or way to the left. We never seem to find that balance where when they decided to get rid of the institutions, the idea back then was they were going to redo them. So we weren't just institutionalizing everybody who someone thought was crazy.
Right.
And then, you know, change in administrations, change in policy and things like that. It never happened. And now you look at it today in the United States, our prisons and jails are full of mental health patients, not
Absolutely.
necessarily people that are criminals.
Right.
It's not to say they didn't do a criminal activity, but there's a good chance that had they
There's a
got the
underlying-
treatment they needed, chances are that they would not have ended up where they're at.
Right.
And so it's really
See, that's that whole
it's sad.
overwhelming process, and that's why they struggle. That's why Matthew's Hope struggles, because the cure to homelessness is it's not like I can just say, okay, you're going to unzip this zipper, take out a wallet, take out $1, give it to you, and put it back. That's not like that. It's there's just so many things that are involved in homelessness. I mean, medical issues, psychological issues, family issues. You know, do they have children? Do they not have children? Do they have, you know, is there a house available? Have they have a criminal record? Do you know how hard it is to find a home if you have a criminal record?
Or a job.
it just goes away.
Yeah.
But the nice thing is we have social media now, Sarah, and I don't know about you, but I personally go to that's where I get all my insight on how to do homelessness, is I go to social media.
Of course, yeah. I think that's a great thing. I think that's,
I
as
have
long
to
as
laugh.
it has, it comes along with a picture of like, one of those people who's the Star Wars guy they're always using?
Darth Vader?
No, the real character. Oh, or like Morgan.
Yes, hold on.
I can't help you with this one. I have no
You know
idea.
what? If you,
But you know how you always see these really intense quotes, and they always have the
Yes.
same like
Yeah.
celebrity behind them.
yeah,
Those kind of things.
yeah.
So
Morgan
Sarah,
Freeman.
oh, there you go. So you have your own practice, so I can't even imagine how busy you are. What motivates you to be a part of Matthew's Hope, helping them?
Well, God told me to come here. I probably would not have had a role with them had it not been an explicit, Sarah, you need to go over to Matthew's Hope and talk to Scott.
How were you introduced to Matthew's Hope?
I just emailed them and,
Yeah.
So you just
I think it was through Messenger. I just said, hey, I want to
so it was
talk
on
to you
social
again.
media. She did learn about homelessness on
No,
social media.
it's funny, and you know how much we use social media. You know the joke behind that,
Yes.
because I mean some of the stuff I read is like, oh, well, why don't we just do that? Okay,
Right.
Well, I can quit doing what I'm doing. I don't have to raise all this money. We'll just do what this person says to solve this problem. No, I will tell you that when the message came through, I didn't waste any time responding to her because I'm going,
No, it was very quick.
holy smokes, there's someone who has is a professional mental health person. It's like, how soon can we talk?
I'm so surprised that more people don't step up, because mental health is so prominent in the homelessness community. So why aren't more people helping?
Well, there's already a shortage of healthcare providers, mental health. I mean, there just is. I have been trying to get a therapist to come work under my umbrella of Excel Psychiatry since it opened, and it's impossible to do. I cannot get one.
Wow.
They just are not available. They're out making good money online, seeing patients online, and and I don't blame them. It's not. I mean, you do have to make a living, but I think to do this kind of work, you really have to have a heart for it.
Definitely.
And
Which I have to remind Sarah of sometimes.
Yeah.
It's okay. Well, she is the unusual. She's the unusual person out there. And don't send me a bunch of nasty grams. Tell me how wonderful your therapist or doctor is. Okay, I just don't have the time to read them all, much less respond to them. But what I mean by that is Sarah is there to truly want to make a difference. I mean, we just recently added at our Brevard location a person that has a doctorate in mental health counseling and psychology. Okay, we can't afford these folks. Okay, and they could go almost anywhere and be paid very handsomely for what they do, because there's such a need. And the truth is, the people that have the most typically get the better care. There's people like Sarah that have made it part of their mission in life to help others and use her profession to do that, to the point where there's sometimes I say to her, it's okay to make a few dollars doing what you're doing. You still have children and you have bills to pay, and you have a practice to take care of. But she's absolutely right. I mean, it took me 2 years from asking from day one. We're 2 years old this week.
Yeah,
over in
the medical part.
over Brevard.
Brevard.
And for 2 years, I've been looking for something, and it just happened. And it's still not exactly what we need. It took more years than that to get. We now have a counselor that comes in and is counseling with our guests.
Good.
We have Sarah that we're working with that is helping people. What I find fascinating, maybe you can touch on it a little bit, is that one of the things we first talked about was using medications that weren't opioid based and narcotic based, and there are great medications out there that are being used that I think people would find interesting to learn about. One of my favorites, and I don't know the name of it, but that will actually make you feel bad if you take part in, like, drinking. If you're a drinker, if you take that, you know what I'm talking. I've heard.
Are you talking about like the old Oh, now I'm right on the spot. You're talking about the one that makes you vomit and all that. Disulfiram?
Yeah.
It has a brand name, but we don't use it anymore because that's why it's kind of in the back of my mind. We don't use it anymore because the reaction is
so
violent.
strong.
Yeah, and it's dangerous.
But the bottom line is there's stuff that's
And
coming
abuse.
out.
And
yeah,
abuse.
yeah, okay, yes. There's stuff that's coming out though that is not addictive, that is working pretty good. The reason you don't hear about it a lot too is because nobody's probably making any money on it.
Right.
It's just my outside opinion sitting here.
Well, there are things available, like for certain conditions, it just is what it is. But I try to utilize, even in my practice, I like Prozac a lot. It's a cheap medication. It's old as dirt, so we know a lot about it. It's very cheap and expensive. I mean, you probably get it 90 days for like $4 somewhere. And it works for a lot of problems. And it's not so much that can I prescribe something for somebody that I know would benefit them. It's where are they going to keep their pills?
Mm-hmm. Right.
What are they going to do? Shove it in their shoe at night? Because they don't want to take their shoes off.
Mm-hmm. Their wet shoe.
They're going to carry it in their backpack, but, if they even turn for a minute, somebody's going to swipe their backpack.
Yeah.
So how do they deal with that? So
not very well, unfortunately.
When somebody gets prescribed a medication.
Well, that's why we've decided to focus more on, and if we have patients who are able, they come to outreach quite regularly.
Okay.
Those Linda actually will keep the medicine there for them. They come in and get it.
Okay.
Give them a week's supply at a time.
Right.
So do pill counts with them because again, with homelessness, often there's a loss of sense of time. And so sometimes they're ahead, sometimes they're behind. It's not necessarily that they're trying to do either.
Right.
It's just, did I do that? I mean, even at, I'll be 62. I just turned 62.
Speaking of time.
Yeah, whoopee-doo. So, wow. So anyhow, that's a realization I have to come through. Maybe if anybody knows how I can get Medicaid, if you could let me know how you go about that, I probably need it. The ADD took off. It just went somewhere there. Hell, I don't even know what I was telling you. So
that's all right. Let's talk about how Matthew's Hope is funded.
The truth is that we just depend on the community.
Okay.
It's still a large proportion of our money. We're having it. Our biggest challenge right now, the largest part of our funding comes from individuals like you and I, pretty middle class people. That really have a grasp that how easy it is to get in this situation. The challenges I see right now is that because our largest donor base is middle class, the middle class has really taken a hard hit the last few years since the start of the pandemic. And so though we see our donor base has grown 14 years in a row, what we have seen is our average donation is about half of what it used to be. Mm. But we're also seeing a larger portion of lack of empathy in people that I've never really seen before. And that concerns me because it makes it tough to fundraise when, I understand the fact that people are going through hard times, and I get it. I'm with you. But the lack of empathy is tough. And that's why I think it's important we do things like the podcast, that if people, if they'll invest a few minutes of their time to learn a little bit about things we've talked about today and other podcasts, that maybe they might see something there. Again, there's no quick, easy fix here. So it comes from individuals. People can visit our website to do that. And right now we have a matching grant of up to $300,000. And now,
incredible.
The good news is there's $300,000 to be matched.
Right.
The bad news is that's worth nothing until it's matched.
So come on, people, let's go.
So when people say to me, "Oh my gosh, $300,000," no, we don't have zero. We have zero right now. It's for every dollar that goes in, it's then matched by a anonymous donor up to $300,000. Right. So if people can keep that in mind, we're right in the beginning of the early stages of summer, and that is traditionally, historically, a time of giving pulls back, and that's when we really struggle. And so it makes it tougher to do some of the things we're able to do with Sarah and the rest of our medical team.
And there's also a fall fundraiser that you guys do every year. You want to talk a little bit about that quickly? We
do. We have 2 fall fundraisers coming up, and the first one is going to be for our Orange County campus, and that's going to be what a lot of people formerly have known as the Garden Party. This year, last year we did Steampunk meets the Wild West. This year we're doing the Roaring Twenties.
Oh, how fun.
And then that's going to be on September, the last Saturday of September. I want to say it's the 30th.
Okay.
I screw up that date all the time.
It's
so don't
on
trust
it's on
me.
Facebook.
Okay. Check on Facebook, double check me. And then November 9th in our Brevard location, we're doing a speakeasy. Similar
exciting.
type of thing over there on our campus. So
Okay.
we've got some opportunities coming up in the fall, but we've got to get to the fall first. And that's where people play an everyday role in getting us
Let's
there.
focus on helping get that 300,000.
We get that 300,000, that turns into 600,000. That'll make it for a lot easier summer.
Right.
Yeah.
Well, Sarah, thank you so much for joining us.
Yeah.
Thank you for all that you're doing because it's really making a difference.
Well, thank you for having me. I enjoy
course.
working with Matthew.
She's a rock star.
She is. She
He
is
always
great.
makes it seem like so much more.
No, it's huge. It's
You
important.
see me looking down. I'm looking down. Yeah, I mean, that's really the rock star. He's kind of
Yes.
crashing right now, but
He does get a lot of attention.
But yeah, I said, well, my gosh, just bring the dog around. If you do something great, that's great. That's a bonus. But he's awesome.
He does. He helps with mental health too.
He does.
He can, yeah. He was donated to me by Canine Companions here locally.
Okay.
They have they have a national organization, but I'm hearing impaired. They donated him to me,
great.
because my service dog. And I do find, even though he's a service dog for me, I have at Matthew's Hope, his presence does bring people down.
That's great. Well, thank you all for watching and listening. Please like, comment, subscribe, and make that donation so we can help Matthew's Hope reach that 300,000 match.